Assalamu alaikum ji. Can I have the slides? All right, so can you move the slides for me? That would be easier. So next slide, please. Or I can do it from here. All right, so what we're going to do is basically my talk is pretty basic, and I'm going to show you some bench tests of stents and techniques, then go through a couple of slides of non-controversial data that we have, established data, and give you a case example of a two-stent technique. Okay, so left main, why are they special? Because they are inherently bifurcations and trifurcations. They are larger than LEDs. There's no perfect technical approach in dealing with left main, and consequences of failure or complications are usually fatal. Now, just quickly go through, these are some Japanese bench tests, and I think I really believe in them because the stent designs have changed, but still there are enough differences with the open cell designs now. So just look at these are for the same balloon dilatations at the same pressures, 3 different stents, the Cypher, the Texas, and the Endeavor. And look at the shapes that they are with the same balloon, same pressures. Okay, so these are some of the things that I want to go through, and then we can summarize the techniques according to this. So the stents are not the same. Why do you need to cross proximally? You can see that if you cross proximally, you will not be able to scaffold the side branch that well. If you cross distally, you are going to have a better scaffold. Now this is the thing that you call crush. Once you crush the stent, the time is also important. Now this is the same stent where you have used the balloon at 16 atmosphere for 15 seconds versus when you've used the balloon for 60 seconds. The general consensus is nowadays the guideline says that it's 26 seconds that you need to dilate. We all dilate a stent for 10 seconds, 15 seconds, but for kissing balloon, good technique, you need to have enough dilatation on the side branch when 2 stents are involved. Now the crush stents, this is the difference when you talk about mini crush, long crush, other things. If you have a 3-layered part at the carina, the shorter and less you have, it looks better and it will behave better in the long term. That's just common sense. So the less you crush, the better it is. The less the 3 layers, the better it is. Okay, so the stent types, if you mix and match stents, they are different. And this is quite authentic with the previous generation stents, and they still remain with the same stents. The Integrity, the Orzyros, the Zinces, they are not the same. Although the essential open cell types are the same. But so Zines and Zines you can see, and you can see if you mix a Texas with Texas, how much extra metal you have at some of the parts where there is where they are mixed together. Stent designs and techniques. Again, look at, this is a 2 different techniques. This is a Colot with the Nobori. Look at the proximal main branch, how it's well covered. Look at Liberty, where there's overlap of kissing balloons. Look how the struts are disrupted. And this is a mini crush where you've used 2 balloons, you've crushed it. So the proximal main branch, look how the stents are there. So the technique matters and the stent designs matter. Final kissing inflation, this DK crush where you do double kissing and crush. Why? Why we were crushing the stents and then recrossing and doing a single dilatation. No kiss, 1-step kiss and 2-stent kiss, the side branch orifice. And obviously if it's rounder and more open without much struts inside, it makes common sense that this would be better. And it has translated into some data also where you can see restenosis rates are less and late loss is less. Okay, stents, this is a basic fact. Stents bend badly. So if you bend something which is metallic, whether it's chromium, platinum, whatever, it will, and this is the reason why. The why and the guide wire, which guide wire you use, the guide wire bias. If you're using a stent in a circumflex, left main circumflex, using a BHW is not the same as using a Pilot or a Workhorse BMW. Okay, which DES? This is an old slide, 2006, I think, or 2000. And not all drugs are the same. The everolimus usually was, and the sirolimus have the least of the MACE and restenosis. So this is again a controversial slide. I think this was an abstract, but this did actually play up later in some of the trials, the Texas trials, where zotololimus and paclitaxel was used. Okay, these are the three. So we are now going on to the data. This is the data that 1 stent or 2 stent, this is all uncontroversial. If you can use a single stent across the left main, that's probably better. But in some cases, you cannot. The other thing is to kiss or not kiss. I think this is again non-controversial. If you can kiss, there is definite benefit. This is the technique. The stent cross-sectional area, if you're using if you're expanding the stents to up to 65%, look at the related to SAT, the events. If you're doing it to 85%, the SAT rates, the subacute thrombosis rates are directly related to the luminal area and how well the total diameter of the stents expanded. So you have to choose the right strategy, and that I would say that it depends on the disease in the left circumflex origin. If in the left main, left circumflex origin, if there is no disease, then you can do with a provisional, which is probably the preferred strategy. But in cases where there is severe disease, then you need to use. So this slide is a little bit busy, but what basically shows is the size of the left main also depends. You need to know which angles there are. The angle B is the most important, and that is where we say 70, 90 degrees or more or less. Okay, so the length of the left main and the angle, whether if it's a short left main, V-stenting, if it's a long left main, and then the angle comes into play and the disease in the left circumflex. Sizing, this is the old Finney's law or Murray's law. But look at the slide here where there is quite a lot of discordance between MLAs and FFRs. And this is just showing that there may be visible less restenosis with a higher MLA but a bad FFR, where there can be a visibly severe stenosis and a smaller MLA, despite that fact that the FFR in this first slide is more than 0.8. So this is essentially the 6, 7, 8 that I call. The 8 millimeter this is the area that you need to have in order to prevent MACE events. So you need to have at least an 8 to 8.5 millimeter area in the proximal left main, and the rest, next is the opposition. Okay, so this is a diagnostic angio of a case that we'll go through, and just so if you look at this, the first thing, this is a left main, clear-cut, simple case, but with some distal LAD disease. And I'm just going to show you the steps that we do in double kiss crush, because I'm not going to discuss Collot and the other data. I'm just going to show you what is important in these things. So sequential balloon dilatation, then you do position your stent, leaving as little as possible into the left main. Step number 3, you deploy. I deploy it, the nominal, then crush the stent. I always open the strut with a small balloon. 4th step, optimize with a bigger balloon distally. Make sure that the distal is NCs. You've done the NC so that in case you cannot recross in certain cases, you still have a large area of the stent which is properly deployed. And you try and now stent the optimize the proximal part. Then this is the first kiss. Fix any distal disease in the circumflex or LAD like in this we did, and then you crush the side branch stent with the main vessel stent. Open again with a small balloon. This is the second KBI. I do it with a small balloon, then do a dot first, and then opening the side branch stent, I optimize it with a 1-to-1 high pressure balloon in the side branch while keeping another balloon in the main, so that you don't get a problem with deploying a balloon through that. Final kissing balloon, then this is important, the pot. Where do you pot? You need to make sure that you pot properly, and then the final pot. Position the balloon and the final pot. And this is just, you should expect a good result. And this is, so this is where in liquidity of time, I'm not going to go through. The take home message is that take your time to review the patient, the indication and the angiogram. Devise your strategy. There has to be a plan A and a plan B, and write it down or at least discuss it with the fellow. Have 2 operators doing left mains. Ensure that all the inventory is there. Remember, not all wires, balloons and stents behave the same. Immaculate technique is required to ensure good result. If in any doubt about size, morphology, etc., use imaging. Persist to your original plan and your preferred technique, but be ready to modify in case of any unexpected scenario. Left main PCI is relatively safe and efficient procedure in the right hands for the right indication, and it seems that it is now here to stay. Left main PCI may look simple, but is technically a challenging procedure. Any error of judgment or a technical mistake usually has fatal consequences. Thank you very much.